Well, thank you. And first, I just want to thank the Indiana Rural Health Association for inviting us to participate, and Allie for all of your help and patience with us as we got through this process. I'm very excited today to introduce Dr. Christina Riojas, a board certified general surgeon. She's also board certified in surgical critical care, fellowship trained in acute care surgery. Dr. Riojas spent 15 years in active duty with the Army. While there, she was deployed a number of times to areas with limited resources, and began to formulate an idea about bringing teletrauma or acute surgical services to rural areas through the wonders of telehealth. Here at Adjacent, we're super fortunate that we met with Christina, and we're working with her to help her build this really exciting program. So with that, I'm going to let her tell you all about teleacute surgical services.
Awesome. Thank you for that introduction. Very excited to be here. This is a topic that I love to talk about. So I have my timer going so that I don't go on too long. But with that being said, a lot of what I'll talk about, even though I will have some statistics that are specific to Indiana, a lot of the principles will actually apply regardless of what state you're in. So stay tuned even if you're not from Indiana. Here are our disclosures, and we'll talk about the objectives here real quick. So at the end of this, I hope that you'll be able to sort of assess and consider the current limitations to access to rural trauma or to trauma care in rural Indiana or rural wherever you are, since this is a nationwide problem. We'll talk about the role of a remote trauma surgeon in the care of a critically injured patient. So whenever people say, oh, hey, you're talking about doing teletrauma, how are you doing surgery remotely? There's a lot of what a trauma surgeon does that doesn't involve touching a patient. We'll talk about some examples of the potential benefits of teletrauma. We'll also acknowledge some of the barriers, and then hopefully you'll be able to brainstorm some of the potential benefits of teletrauma at your facility. I've had a lot of conversations with people, and there's a whole laundry list of potential benefits of this service. Some are more applicable to different facilities, and I've even learned more just by talking to different facilities about what problems they have that we can potentially address. So again, this is a nationwide problem. The goal with trauma care is the right patient in the right place at the right time, receiving the right care. So more than 75% of rural America is greater than an hour away from a trauma center. So this delay in care leads to potential lost lives, increased morbidity and mortality. So in the state of Indiana, a white paper was written back in 2012, kind of addressing how injury was so problematic for patients in rural areas. So a couple key points that they talked about. In this map here that you see is a map that outlines being 45 minutes based on road conditions and weather and all that stuff, about 45 minutes from a trauma center. So this is about 25% of the state, or about 58% of the population, back in May of 2012 when this paper was published. So these are the main issues that they saw of why injury is problematic in rural areas. So transport, even if an ambulance is available, which it's often not, transport can take a long time, again, depending on weather, rural geography, all those kind of things. In rural hospitals, there's a lack of access to subspecialty care. It's not beneficial necessarily to have all the expertise in all the rural areas. We don't have enough trauma surgeons and experts to get to all these small hospitals. Transfer, even when a transfer is started early, can take a long time to arrange a transfer. And just sicker patients in rural areas. These patients are often older, have comorbidities, and they tend to have less access to regular medical care. So even just their diabetes, their high blood pressure, their heart disease, may not be as well cared for, which sets them up for more problems when they do get injured. And then dangerous occupations, again, depending on what part of the state or what part of the country, you can have miners, farmers, lumberjacks, people who operate heavy equipment and have some pretty horrific injuries. So some of the solutions that were proposed: improving the statewide trauma system. Trauma systems are shown to save lives. Having similar to the continuum of care for heart disease, or acute coronary syndrome, where the chains, the links of more rapid access to care, improve cardiac outcomes. It's the same for trauma patients, having established systems for communication, rapid transfer, education, feedback, all those kind of things. Another thing that was proposed was getting more EMS providers in rural areas. And then what about getting the patient to the trauma surgeon for management? So what sounds like a simple idea of just get more trauma centers, it's much easier said than done. So there is a significant shortage of trauma surgeons. The national population is rapidly outstripping the number of trauma surgeons that we have. This is leading to an increased trauma surgeon density, which leads to increased mortality. We just can't, again, getting more surgeons also isn't the answer, because trauma care is based on a team. It's not just the surgeon. You can't just transport a trauma surgeon to a rural facility and expect patient care to improve. It's kind of a whole system that has to go along with that. So looking at this map, so this was published in 2022, so 10 years after the first map was published. And you look at this and go, okay, now what is the percentage here? It was up to 74% of the state, up from just a quarter of the state, and 92% of the patient population now has access within 45 minutes. You say, awesome, people can get to trauma centers. A couple of problems though is this doesn't account for the level 3 and level 4 trauma centers. So the patients are still a long way from a trauma surgeon. For all intents and purposes, a level 1 and level 2 are pretty much equivalent for the acute care of the patient. Level 3 and level 4 aren't required to have a trauma surgeon. And it's just not the same level of care. So it's better. It's definitely an improvement to have better access to a level 3, level 4 being part of the trauma system, rapid transfers, but still isn't the same as getting a trauma surgeon to these small areas. So what is teletrauma? So telemedicine, telehealth that tele is just talking about using technology to improve access to care. So teletrauma, again, a lot of what a trauma surgeon doesn't involve necessarily touching the patient. There's a lot that goes into assessing the patient, advising on assessment and management, minimizing delays. So saying, hey, this is a procedure that's not necessarily needed, isn't going to change their care. Let's focus on getting the patient into the ambulance and getting them to the higher level of care. And then talking about recommendations for patient disposition. So there are patients who maybe have minor injuries, or say someone has 2 rib fractures and a forearm fracture. Your orthopedic surgeon might say, hey, we can fix that forearm fracture. Your medicine doctor's like, hey, I don't manage patients with rib fractures. Is this someone who needs to go to a trauma surgeon? That patient doesn't necessarily need a trauma surgeon to operate on them, so they don't need hands-on, but the expertise that goes with understanding that a patient who has an orthopedic injury, they get their surgery, the common thought might be to hold off on DVT prophylaxis. They just had surgery, and the medicine doc's like, well, I'm going to wait for ortho to tell me, when I can start this. A trauma surgeon can come in and say, hey, it's okay to start the DVT prophylaxis, make sure they're breathing okay from their rib fractures, all those kind of things. And if you can save that transfer from the level 1 or level 2 facility, that's a win, keeping that patient closer to their facility or to their home. This can alleviate provider anxiety. So the facility that doesn't see trauma that frequently, but when they do, it can be a really badly injured, sick patient. It can avoid deviations in care. It can expedite transfer for those patients who need to be transferred, and it can optimize their resuscitation while awaiting that transfer, and then minimize those non-therapeutic transfers. So the patient who really doesn't benefit from physically being in a level 1 trauma center. So very brief history of teletrauma. So with the emergence of telemedicine, the subspecialty expertise is no longer confined to the big cities, the big hospitals, those tertiary care facilities. It all used to be restricted to or limited to face-to-face interaction with the specialist. Back in 1976 was the first reported use of telemedicine to provide trauma care. And since then, it has been shown in multiple studies, the references are down at the bottom and the longer references are at the end of the presentation if you're interested. But they've been able to show improved patient care through life-saving interventions, education, avoidance of unnecessary procedures prior to transfer, which again helps expedite that transfer, and then minimize those non-therapeutic transfers and the associated costs, both to the patient's family, tertiary care centers, the healthcare system as a whole. So case for teletrauma. So again, there are a multitude of patient scenarios or patient conditions that could potentially benefit from this, but I'll talk about this case that really brought this home for me and has stuck in my mind since the day it happened. So this is when I was in San Antonio, Texas. We had a very large catchment area. This patient happened to live far from the nearest hospital, which was not a trauma center. But anyway, she was stabbed at home by her significant other. So it took the ambulance a long time to get to her. When they arrived, they put her in the back of the ambulance and then start towards the hospital. She actually lost her pulses en route. So got CPR. She had a tension pneumothorax, which wasn't decompressed, which is a whole other issue that does need to be solved. But either way, she gets CPR. She arrives at a 4-bed ER. The most senior clinician is a nurse practitioner, thankfully a very experienced nurse practitioner. But that's it. There's no pharmacist. There's no other expertise. It's her. So she's doing the care for the patient. She's doing her own drug calculations. She's, intubating the patient, everything that this patient needs. So about 30 minutes later, she gets me on the phone. It's not that it took her 30 minutes to get a hold of me, but she's doing patient care. And then, someone needs to call and get the transfer center and all that stuff. And then she now has to spend time retelling me the story. And in the middle of, I have this image of her with her phone pinned to her ear. She's talking to me, her work phone. And then on her personal phone, she's doing her drug calculations and maybe looking up a dosage of something because she doesn't have any help. So imagining what this could have looked like if she had teletrauma. So we could have been on the phone even before the patient arrived. They had an alert that the patient was coming in. So we could have talked about what, making sure that things, whatever could be in the room was in the room when the patient arrived. But the big thing is freeing up her hands and the hands of the whole team really to care for the patient instead of holding the phone, instead of focusing her time on repeating the clinical timeline of when everything happened. Again, while she's doing tasks that she shouldn't have to do, she shouldn't be doing drug calculations. I can do drug calculations while she's, again, saving the life of the patient. But allowing all of their attention to be focused on the patient and have an extra set of eyes and ears that's watching the room, working on getting the transfer, all the things in the background that can't be happening simultaneously with doing direct patient care. So what can a remote trauma surgeon do to support the local team? So four main ones, and we'll talk about each of them. So improving patient care, minimizing those non-therapeutic transfers, more rapid transfer initiation for the patients who need it, as well as optimizing their care while awaiting transfer. And then that trauma system integration, education, performance improvement, all those things that go along, not necessarily with the direct patient care, but just improving the system and the hospital as a whole. So improving patient care, there are so many things that have been cited in the literature of specific cases that have been directly impacted by the video consultation part of teletrauma. There's a lot that can be done on the phone, but there's a lot to be said for being able to lay eyes on a patient and facilitating the patient's care. So again, this allows the providers to maintain the focus on caring for the patient, hands-on, only what someone in person can do. So it can be everything from guiding resuscitation, doing temporizing interventions, everything from making sure tourniquets are placed correctly, making sure the pelvic binder is on the correct place, procedures that they might not have done recently. If you haven't done a chest tube in a while, you might be a little bit nervous. So if you have someone who, it's not a time to learn how to do a chest tube or learn how to do some novel procedure, but it's, hey, can you just be here with me as we're looking at this, make sure that we're doing things the way they need to be done. Again, prioritizing interventions and studies. So saying, hey, we don't need to send them through a CAT scanner if they have fluid in their abdomen and they're unstable. We already kind of know what they need. And then rapid consultation and disposition planning. So we can kind of get ahead of things and say, yeah, they're going to have to be transferred, and we can start working on that process. So some of the procedures or some of the interventions that have been done with the assistance of the video is assisting with intubation or central line placement, volume resuscitation. So there was a patient who on the phone, they reported the GCS at 15. And then when they did a video consultation, they actually found the GCS to be 5. Again, that sounds kind of dramatic. And you would say, how does someone misread or miscalculate someone's GCS? It's not necessarily an issue of education. It's not that the people at whatever facility don't know how to take care of trauma patients, but when you have a sick person in front of you, things that seem straightforward, in a ATLS class can be less straightforward. There was another patient who had a gunshot wound to the neck, they had a venous injury, expanding hematoma. So the trauma surgeon was able to say, hey, that could be a potential airway compromise. We need to get that patient intubated before they get in the ambulance. Someone else with a temporal artery laceration, which can bleed a lot, but doing some directed suture ligation. Again, if that's not something that you've done before and you're at a remote place and you got a stack of gauze on, you're like, how am I supposed to deal with this? Just having someone there that you can talk to that says, hey, like, we can put some stitches in this and stop that bleeding. Someone else with TBI and severe agitation, just the guidance to say, hey, they need to be intubated and transferred. Let's get that rolling, probably stop. Don't worry about other procedures or interventions, just the things that they need to get them ready to transfer. Minimizing those non-therapeutic transfers. So this is all about caring for the patient at the most appropriate facility. So again, there will be patients who need to go to the level 1 or level 2 trauma facility. That's not a question. Those are going to continue to happen. There'll be plenty of patients who don't need that transfer. This minimizes healthcare costs and optimizes your resource utilization at both facilities. So you keep the patients who, again, don't need the resources of a level 1 trauma center, you keep them at the smaller facilities, and you let the team at the larger facility take care of the higher acuity patients. So in Indiana, half of the patients arriving to a level 1 and nearly 40% of patients who are arriving at a level 2 are transferred for another facility. So I don't have the specifics of how many of those patients needed that transfer. We have the data already that shows that there's a large number of patients who do have non-therapeutic transfers, but this is definitely a number that can be addressed. So a couple patients scenarios to talk about with those non-therapeutic transfers. So patients with mild TBI. So the brain injury guidelines, big criteria, where you assess a patient's Glasgow Coma Scale, you assess the type of bleed and the size of their bleed, whether or not they're on blood thinners, whether or not they're drinking, whether they have a skull fracture, a couple other things. And then based on that, you can make the decision of which of those 3, if they're big 1, big 2, or big 3, based on how severe their bleed is and their neurologic exam, and then determine which patients actually need further imaging or neurosurgical consultation. So if you have a patient with a big 1 and a normal mental status and a small head bleed, they don't need to go to a trauma center. It's hard to it can be hard to say that on the phone to someone who say, hey, you have blood in your head, but I talked to the surgeon, we're not going to send you to the trauma center. But if you can get a video where you're in concert with a local provider and you say, hey, I've assessed you, I've looked at your mental status, I've reviewed your CAT scan, and we can observe you for 6 hours. And as long as your mental status stays okay, then you're safe to go home. We have the data to back this up. If someone's going to say, hey, they have blood in their brain, we always have to go to the brain surgeon to be evaluated for this. No, we've shown based on these criteria that you don't need to be transferred. Isolated rib fractures. Again, there's certain criteria based on their incentive spirometry use, their pain control, and just the general status of the patient, their fragility and everything, that could potentially be discharged and not need to be transferred. Someone with a trace pneumothorax, so pneumothorax that isn't seen on x-ray, but is seen on CAT scan. If you do a repeat image in a couple hours and it doesn't change, that patient can be discharged. A big one is wounds to extremities. So it's scary to have a patient with a stab wound or a gunshot wound, even scarier, to the leg. And the common thought is that those patients all have to be transferred. And a lot of those patients do, but if you can rule out a bony injury, so they don't have a fracture, they don't have an underlying fracture, their nerves and their blood vessels are okay, and they can get up and move around okay, there's nothing that's going to be done differently at the trauma center. So you don't necessarily need to see them or send them to be seen. And then the other group of patients that have an indication for admission or observation, but again, if they don't need hands-on from a trauma surgeon, again, patient with a couple rib fractures, but then a forearm fracture or something else that needs to be addressed, or a geriatric patient with a couple rib fractures that you want to watch them overnight, you can just, round the next day, discuss the need for additional or follow-up imaging, do the tertiary survey, and again, keep the patient without having to send them to a trauma center. There's non-therapeutic transfers. So preventing 17 non-therapeutic transfers can save over $100,000. And the numbers are not perfectly clear cut. This is what has been shown in the literature. It depends. There are a lot of factors that go into this, obviously, but this is to show that that this really is a cost-saving intervention. Preventing one air ambulance transfer was actually able to cover the cost of the telemedicine program at one facility. Another patient, the telemedicine cost for a consultation was $1,740. They saved a total of $5,500 and had a net saving of nearly $4,000. So yes, telemedicine does cost, but if you're able to save a lot in the end, you can have net savings. And then the average hospital bill after secondary triage, so a patient who gets transferred, but again, didn't benefit from that transfer, over $9,000. That's a lot. More rapid transfers. So again, the patients who need to go often need to go quicker, not waiting around for unnecessary procedures, not, getting additional blood work that's not going to change the care, all that kind of stuff. No need to wait for a callback or repeating the information. And all the time that goes in on both sides of the transfer of both the sending facility and the receiving facility. In addition, you can prepare the receiving team. So the trauma surgeon calling the level 1 trauma center saying, hey, this is what you're getting. Prepare your IR team because I think they're going to need an embolization or something like that. There are additional pieces that can be done upfront to make the team better prepared. And then last but not least, the trauma system integration, performance improvement, and education. So again, right place, right time, right patient, while minimizing the duplication of expensive resources. So this continuum of care for patients with cooperation and communication, again, interrupting this is what costs lives in patient care. So anything that you can do, anything that can be done to smooth that out is better for patients. And then performance improvement, where you're able to do reviews of the cases. You have that information. You're able to say, hey, was there something that we could have done different here? Did this patient really need to go? Did they need to go and we missed it and they needed, or should they have gone faster? Did we waste time doing whatever procedures, or did we transfer them? And then in hindsight, yeah, there was something that we could have managed without transferring them. So barriers. So why hasn't teletrauma caught on? This was first reported in the literature back in 1976. And we've continued to write about it in our literature as recently as November of last year, where an article was published by Dr. Hashmi from the University of Alabama in Birmingham, which basically is outlining that everything that I'm telling you, and then talks about what the barriers have been. So we've worked through a lot of these issues with funding, as reimbursement for telemedicine is improved, working on staffing, working on how to integrate this into existing trauma systems, coming up with clinical workflows and a training curriculum. Not insurmountable, but definitely need to be addressed as we work on launching this. Most importantly, the benefits. So who benefits from this? So patients benefit, improved clinical outcomes. So again, right patient, right place, right time, right care. Rapid access to care and rapid transfer makes patients do better. And then decreasing those non-therapeutic transfers. A lot of benefits that are second and third order to those decreased transfers, everything from cost to just the risk of having another accident when you're getting transferred, the inconvenience to the patient and their family, just the mental anguish that comes with, hey, my patient, my family member has to be transferred. That must mean they're really sick. Even the transport, like family having to drive hours away to go to this hospital, just to see their loved one. Even non-trauma patients benefit. So you say if we improve patient care for patients who are having traumatic emergencies, how does a non-trauma patient benefit from that? So interestingly, if you are having a cardiac event in an emergency department and a trauma activation comes in, you are likely to have worse outcomes from your cardiac event. The resources that are needed that are diverted away from the patient having the cardiac event to manage the trauma patient. So those patients are still, those accidents are still going to happen. Patients will still come in. But if we can avoid that transfer of a patient coming in and diverting those resources, then you can, again, continue to let the resources be used for the sick patients, and keep that non-sick patient away from the level 1 trauma center. How do the rural facilities benefit? So better patient care while avoiding the cost of an on-site surgeon, allowing those providers to focus their attention on the patient and be more comfortable caring for and dispositioning injured patients. Just knowing that there's someone that you can talk to run things by, and it doesn't have to just be a conversation of, hey, I have this guy, I think we need to transfer them. Even just having the discussion of, is this a resource that we have here? And knowing that you can get follow-up can make that difference. Talk about education, doing debriefing, even just talking about cases where we say, hey, is there something that we could have done better in this case? Does someone need additional education? Does someone need training on the ultrasound? Or, do we need to talk to the blood bank about, expediting transfusion or whatever it is? Being an integrated component of the state trauma system is, again, a big part of improving that communication. And then decreased ER wait time. If you are dispositioning patients faster, you can get them out and get other patients seen. The trauma centers benefit because you basically, again, continue to allow them to focus their time and energy on patients who are the highest acuity. The patients who still need to be transferred are hopefully optimized, with regard to resuscitation. And then the receiving facility can also activate their MTB, activate their OR, call in their IR team, whatever needs to be done just to get that little edge of faster access to care. And then a comprehensive record of the resuscitation workup and management, minimizing, the telephone game where it's this provider talking to this provider talking to, you just get the trauma surgeon who was involved in the care in the beginning, calls and says, hey, this is a trauma patient that needs to come to you. Yeah. Okay, and then the healthcare system and society in general, again, as globally, this improved resource utilization improves care at all facilities because patients are kept where they need to be, and we don't spend money transferring patients who don't need it, caring for patients who don't need it. Even just the decreased carbon footprint of allowing ambulances to be used for the sickest patients, and keeping ambulances off the road that don't need to be there. So these were the objectives that we talked about. So summary, right patient, right place, right time. This limited access to care, which is, again, not an isolated problem in Indiana, but in all states with rural areas, leads to unnecessary morbidity and mortality. Some of the solutions that have been mentioned are improving trauma systems, getting EMS in rural areas, and then other solutions are remote access to that trauma expertise. Talked about some of the capabilities of teletrauma to improve patient care, minimize non-therapeutic transfers, allow more rapid transfer initiation, and facilitate integration into the trauma system, as well as education and performance improvements. Benefits are numerous, and these are my references. So as Karen mentioned, I am working with Adjacent Health. So just a little bit about Adjacent. So we're currently providing teleneurology services across the country in 130 facilities, 42 hospital systems, and in 19 states, including in Indiana. We use a teledoc platform for all of our clients. Regarding telemedicine for acute care surgery, so we currently have a hospital in Wisconsin that we are establishing a telesurgery consultation service for. And we're currently in discussion with a couple hospitals who are very interested in being pilot partners with us for teletrauma. And I'm happy to answer any questions, or either now or in an email. That's the email, and that's just a QR code to my email. So thank you. Gotcha.
I would think too, one of the benefits maybe that you didn't mention, or perhaps I didn't hear it this time, but I think we talked about when you and I spoke, but recruitment and retention of doctors,
Oh,
knowing, especially new doctors, maybe
yeah.
that haven't done anything like this in the past, just having that extra somebody there to provide support and talk them through anything they want to talk through, could be very
Yeah.
beneficial.
Yeah, absolutely. So the facility up in Wisconsin, when I spoke with the surgeon up there, he was like, the freedom that it would give him to even just have a longer career where he isn't taking those phone calls at night is a little bit different because it's not trauma, but it's acute care surgery, of not taking those phone calls would do a lot for his longevity as a surgeon. But yeah, I've talked to multiple ER physicians, a handful of general surgeons, and even non-clinicians who have colleagues or family or friends where they say just knowing that there's someone we can talk to makes a huge difference, or knowing that there would be someone we can talk to. So if that's something that you could offer to your providers coming in, where you say, we're not a level 1 or 2, but we have access to that consultation. And also for liability as well, where you can say, hey, this is an additional expertise that we can provide for our patients.
We did have one question just come in the Q&A, which is, how long does it take to activate a new program? 90 days, less?
Oh, that is a good question. So we haven't launched one yet, but once the biggest time delay or lag for time is the credentialing and licensing. So you have to, the physicians have to have a state license in whatever state the facility is, and have to get credentials at that facility. At Adjacent, we have a team, a credentialing and licensing team that is on top of all of that. But that's the one real time limitation of getting a program off the ground. Yeah, happy to talk with anyone about this. Like I said, I've learned a lot just from having conversations with potential clients or other people in the industry where people have asked questions and, I've brought up things that I didn't think about, or made suggestions. All that information is incredibly helpful. And really at the end of the day, our goal is to address the needs of the hospital, because that's what we're here for, to improve patient care in whatever ways that the hospital feels are most relevant.